thank you so much to Del for that first presentation and for kicking things off today. Yeah, such a brilliant paper and discussion as well. I look forward to hearing more. So the next session then, we'll have Ian Morland and Peter Hegarty. Just in terms of timing, we're going to have 20-minute papers from each panelist, and then 10 minutes of questions, hopefully with 10 minutes break then before the next panel. To introduce our speakers then, Ian Morland is an independent scholar, and with Li-Mei Liao was the founder of Critical Sexology. He's the author of numerous works on intersex, queer theory and sexology, and he's co-author with Lisa Downing and Nikki Sullivan of Fuckology, Critical Essays on John Money's Diagnostic Concepts. To introduce Peter as well, then Peter Hegarty is Professor of Psychology at the Open University. His research is in the field of social psychology and focuses on the relationships between sexology and masculinity, and between psychology and lesbian and gay movements historically and in the present. His books are Gentleman's Agreement, Alfred Kinsey, Lewis Terman and the Sexual Politics of Smart Men, and A Recent History of Gay and Lesbian Psychology. So a very warm welcome to Ian and Peter, although I'm much newer to critical sexology than either of you. So thank you very much for agreeing to speak today. It's a real pleasure to chair. Who's kicking things off today, Ian or Peter? Who would like to go first? I'm not sure who you're pointing to.
I'm happy to.
Perfect, Ian. Thank you very much then, Ian. So if we, take it away.
Okay, thank you. One of the nice things with critical sexology has always been the range of different formats and styles of address. So being a humanities person by training, I have written a paper and I've even given it a title, and I'm going to read it out. I don't have any slides, but hopefully I'll keep everyone's attention. The title of my paper is Making Medical People. And the question I want to start with is, how does diagnostic language make us who we are? In 2005, a group of critics, including the patient activist Cheryl Chase and the medical historian Alice Drager, published a paper that admonished the contemporary diagnostic terminology of true hermaphroditism and pseudo-hermaphroditism as being illogical, outdated, and harmful. Typified by a mixture of ovarian and testicular tissue, so-called true hermaphroditism is highly unusual. The effect of naming it the true form of sexual ambiguity was to rarefy intersex. What's more, because the gonads in true hermaphroditism usually don't function, to call this state true was to cast sexual ambiguity as non-functional by definition. Pseudo-hermaphroditism, where either ovaries or testes are present and may be functional, is more common. Yet this pseudo prefix implied that a body is not really intersex, but could instead be classified as female or male on the basis of its gonads. In the year after their paper, Chase and Drager were among the contributors to a pair of handbooks for clinicians and families. These 2006 handbooks advocated the reform of medical treatment for sexual ambiguity, including a halt to genital cosmetic surgery in infancy. In the handbooks, diagnoses such as true and pseudo-hermaphrodite were subsumed into a new umbrella phrase, disorders of sex development. So too were the words intersex and intersexuality. Clinical uptake of this phrase, disorders of sex development, abbreviated to DSD, was swift. It was quickened by the fact that preparation of the two handbooks coincided with a conference organised by the major paediatric endocrinology societies. At the conference, Chase distributed drafts of the handbooks to the participants. Conference participants embraced DSD as an umbrella term, and they defined it as follows: congenital conditions in which development of chromosomal, gonadal, or anatomical sex is atypical. Under this, they delineated some new categories, such as 46XY DSD and 46XX DSD, referring to the chromosomes, to include the conditions that were previously called pseudohermaphroditism, and another subcategory called ovotesticular DSD to replace true hermaphroditism. Now, like the handbooks, these conference participants advocated the terminology to supersede not only diagnoses based on the word hermaphrodite, but also the term intersex. And the output of the conference was a collaboratively written policy statement that addressed both terminology and treatment, and it was published in leading pediatrics journals in 2006. Criticisms of this change in terminology emerged rapidly too, starting with objections by some of the contributors to the handbooks. Centering on the use of the word disorder, complaints fell into two broad groups. Some commentators accepted the premise that diagnostic language should be revised to facilitate treatment reform, but they objected to the characterization of certain types of sex development as disordered, and they preferred more neutral phrases such as differences or variations of sex development. Other critics of the DSD terminology argued against diagnostic language altogether. To these commentators, the problem was not primarily the word disorder, as if the selection of a different word might make the problem go away. Instead, the problem was the authority of clinicians to name bodies in the first place. Now, these critics preferred the retention of intersex. An additional group of commentators adopted a mixed position, either by employing a combination of DSD and intersex, or by leaving the first letter of DSD open to interpretation as both disorders and differences. Now, the question of whether DSD is an improvement pivots for many commentators on whether diagnostic language determines the identities of patients. In the 2005 article that made the case for discarding the language of hermaphroditism, Chase, Drager, and their co-authors criticized the existing diagnostic language for its representation of people. Their complaint centered on the depiction of patients as hermaphrodites. So by their account, the prevailing practice at the time of naming the whole person according to the condition conferred on affected individuals all the negative overtones of the diagnosis itself: spurious, non-functional, outlandishly rare. The terminology of hermaphroditism thereby constructed a problematic type of person, in the words of Ellen Feder and Katrina Karkazis. Now, for those who see the introduction of DSD as a catalyst for the transformation of medical practice, the new terminology usefully separates diagnosis from identity. And this is because, unlike both hermaphrodite and intersex, it names the bodily characteristics that patients have instead of the types of people that patients are. Many writers on DSD have dwelt on this relationship between diagnostic language and patient identities. But the shared interest hasn't really given rise to a mutual understanding of what that relationship means, what it should be, or whether it should exist at all. Today, I want to ask a different kind of question. Now, we already know that medical treatment constructs patient bodies, but that's not the whole story. I want to consider the bodies that clinicians inhabit and what they do with them. So moving beyond the question of whether DSD characterizes patients as disordered, this is a matter of how the embodied acts of diagnosing and treating DSDs define doctors, how medical people are made. The policy statement that followed the 2005 conference advocated changing the way in which sexual ambiguity is diagnosed and treated, not just by introducing new terms, but also by altering how and when clinicians make decisions. Now, whereas traditionally, affected infants were assigned to a gender as promptly as possible, according to the surgical ease with which their genitals could be made to look female or male, the policy statement after the conference advised a slower decision-making process, and one that was not propelled by surgical considerations. It recommended that gender assignments, and this is a quote, must be avoided prior to expert evaluation in newborns. And it also stipulated that both this diagnostic evaluation and later treatments should be done by, and this is another key quote, an experienced multidisciplinary team. Challenging the idea that surgeons have sufficient expertise to assign gender, the statement made consultation across disciplines the standard for good practice. It proposed the involvement of specialists from, and this is a list of the areas that it proposed, endocrinology, surgery and/or urology, psychology/psychiatry, gynecology, genetics, neonatology, and, if available, social work, nursing, and medical ethics. The statement also encouraged the participation of patients and families in decisions with the multidisciplinary team. The statement received criticism, however, for overstating the potential for such teamwork to achieve change. According to the sociologist and patient advocate Georgianne Davis, the multidisciplinary team that's envisaged by the policy statement is firstly too large and secondly insufficiently diverse. Though the team members may privately debate treatment options and admit their uncertainty, the size of the team can give to patients and families an impression of comprehensive authority and an excessive degree of certainty, which actually deters them from seeking alternative opinions. And what's more, because such a team is composed mostly of clinical disciplines, its members are unlikely to consider seriously social explanations for gender, for sex, and for sexuality, or to discuss these with patients and families. Now, Georgianne Davis argues that the combined result of these factors is that the advice provided by multidisciplinary teams may be oversimplified and unduly medicalized. Some other critics have argued similarly that the proliferation of disciplines involved in diagnosis and treatment doesn't diffuse medical authority, but it actually sustains it, or it even intensifies it. Davis's critique highlights that simply adding or changing specialisms in a multidisciplinary team may not improve care for affected individuals. Indeed, the policy statement recognized the need for team members to undertake dedicated training, as well as for them to educate other professionals that the team interacts with. There was a follow-up statement, another policy statement in 2016, that advocated greater shared responsibility between the disciplines for the clinical decisions that the teams make. Now, regardless of whether you're sympathetic or skeptical towards the approach recommended by the original statement, I think that multidisciplinary teams embody ideas about work, and these ideas deserve some critical scrutiny. If we take it back to basics, at base, the diagnosis and treatment of affected individuals requires effort. The amount of effort required is partly a reflection of the terminological change to DSD. As the statement put it, the new terminology increases the obligation on medical professionals to, and here's a quote, employ precision when applying definitions and diagnostic labels. So categories like 46XY DSD are intended as only the starting point for more individualized diagnoses based on specific etiologies. This kind of precision takes time to achieve, and that's why you can have a delay in gender assignment while the work is underway. The types of diagnostic work on newborns that are described by the policy statement include genetic testing, physical examination, ultrasound imaging, and 6 types of biochemical test. These are all specialized kinds of work, instances of what social theorists have called the division of labor. Now, dividing labor into different specialisms, here genetics, pediatrics, radiology, and biochemistry, is a prerequisite for the formation of multidisciplinary teams. But when we assume that disciplines are the building blocks of an effective response to sexual ambiguity, there's a risk that we may place the division of labor beyond critique. In other words, even if the composition of multidisciplinary teams can challenge the dominance of surgery in clinical decisions, the specialization of work into disciplines is likely to go unquestioned. The lack of critical attention to this division of labor is especially clear, I think, in discussions about the role of psychology in multidisciplinary teams. The policy statement mandated that psychosocial care provided by mental health staff must be an integral part of management, or even, as one of the lead authors of the statement elaborated, at the heart of how teams treat affected individuals. Now, this requirement implies that the discipline of psychology is uniquely capable of transforming practice, as opposed to being merely one specialism among others. Now, accordingly, some see the inclusion of psychologists in multidisciplinary teams as evidence that medical practice has changed following the introduction of the DSD terminology. One leading British team has argued that the presence of a psychologist shows that the whole team recognises that physical and psychological care are interrelated. Nevertheless, the 2016 follow-up policy statement conceded that psychology in DSD treatment and research is typically characterized either solely about gender in the brain or characterized as a vague placeholder for all social and psychological concerns. So this use of psychology as a kind of passive emotional repository has received criticism from our own Li Mei Liao and also the patient advocate Margaret Simmons. And they've observed that psychologists often lack the power to challenge clinical decisions, despite the fact that they're members of the multidisciplinary team. Liao and Simmons are among a group of critics who propose more wide-ranging and subversive roles for psychologists. I think I'd include Peter in this group as well, from facilitating overall team development and training team members from other disciplines, to interrogating how clinicians think and scrutinizing the ways in which concepts from psychology get used to justify medical interventions. Now, I would argue that none of these proposed roles for psychologists actually puts in question the division of labor. They just alter the labor assigned to psychologists. So like the original policy statement, many of these proposals cast psychology as a uniquely transformative discipline. And in this respect, they can maintain the assumption that the problem of achieving medical change is solvable by specialization. So in my view, to specialize in any given discipline is to adopt ways of moving and touching that are discipline specific. Specialization is embodied. Patients are not the only bodies in the clinical encounter, but this fact is generally overlooked. In acts of diagnosis and treatment, the bodies of multidisciplinary team members labor over the bodies of their patients. And they move differently according to their specializations. They touch patient bodies in different ways. And these vary from manual palpation and dilation to more mediated interactions, like the slithery touch of the ultrasound transducer or the graze of the needle. So the metal tools of surgery differ from the verbal tools of psychology. So these disciplines make distinctive demands upon the bodies of practitioners. And through differences in their movement and their touch, labor is divided between the bodies of team members. Specialization also means learning how to touch the tools that produce forms of knowledge that are specific to your discipline. The geneticist doesn't palpate the patient, for example, but they touch the apparatus of genetic analysis to create diagnostic information from cellular samples. In a multidisciplinary team, each body's discipline-specific movements distinguish its labor from the labor of others. As disciplines change, the differences vary, but the division of labor remains. And what's more then, calls to transform medical practice are generally assimilated into the division of labor to become discipline-specific types of work. And this is exemplified by the transformative role assigned to psychology. Criticisms of surgery have not just driven the addition of psychology into multidisciplinary teams, but they've become psychology's own speciality, the labor of critique. So the division of labor always gives bodies something to do. Now, cultural critics are accustomed to thinking of gender as a corporeal style, following Judith Butler's analysis in her 1990 book, Gender Trouble. But I would say that we should consider the embodied qualities of multidisciplinary labor as corporeal styles as well. To represent a discipline as a member of a multidisciplinary team is to move in a corporeal style that's separate from the styles of your co-workers. Butler argued that corporeal styles imply the existence of an abiding self, which motivates behavior and is expressed by it. For Butler, the self doesn't come before the style, but the style makes it seem that way. So with this in mind, we can revisit the policy statement's apparently self-evident recommendation that patient bodies ought to undergo expert evaluation. Being an expert, such as a surgeon or a psychologist, implies fluency in a corporeal style, the authority, comfort, and legibility with which your embodied movements evaluate and treat patients according to the conventions of a discipline. But after Butler, I would turn this observation around. It's the fluency in a corporeal style that suggests the presence of an expert self who drives the stylized movements of the body. So that's to say that the performance of specialized work implies the existence of a type of person, the expert, behind the work. And this normalizes work as an expression of the self, so that specialization seems to originate in the expert rather than in the division of labor. And the division of labor is both sustained and concealed by the idea that types of people pre-exist the specialized work that they perform. So to close, I think it would be a mistake to assess medical change by whether particular experts are included in multidisciplinary teams. Expert evaluation sounds uncontentious, but dividing labor between experts frames the question of change in medicine as an issue of who should be working rather than whether work should be done at all. And that's the question I think we should be asking. And to truly ask it, we may need to let go of who we think we are.
Thank you so much, Ian. That was a fantastic paper to open this panel. Moving straight on then, as we're pressed for time today, so we'll move straight on to Peter. I'll hand you over.
Thank you very much. Let me just see if I can share a screen here. Lisa's giving me a thumbs up. That's looking very good. Okay, great. I think this paper will pick up on the other two, but take it in Critsex style into a very different disciplinary space, that of psychology, not clinical psychology, but social psychology. I'm going to talk about conceptualizing essential medical interventions on VSC, variable sex characteristics, with DSD professionals and with the general public. It's really nice to think about this as a 20-year span. 20 years ago, I wrote a paper with Bo Laurent, then known to me as Cheryl Chase, which was one of the first that examined what the emergence of intersex activism might mean for the discipline and field of psychology, which Ian Morland was kind enough to reprint a few years later. When I moved to the UK in 2002, it was that paper that brought me into contact with Lee May and then Ian and then everybody else in Critsex. So 20 years later, I'm going to talk today and center this on two papers that have been published online in the last 6 weeks or so, one of which is very qualitative and one of which is very quantitative. One of which is about DSD professionals, one of which is about the general public. The first comes out of a project called SENS, which is an international research study conducted in Scotland, England, Norway, and Sweden, with some people Del has already mentioned, Katrina and Tuva, and also Lee May. And our research question was, how do people make sense of sex development that diverges from binary sex norms and clinical interventions that are brought into play in relation to sex development? To explore the question, we conducted over 80 interviews with medical professionals, young people, and parents and carers, and a number of focus groups with naive people who were not personally or professionally affected by the issues. Oops, what's happening here? There we go. Yeah. I'm going to talk about the interviews with DSD professionals today, which were conducted by Katrina. And at the start of that interview, she asked all of them to think about the kinds of interventions that were performed on VSC in their teams. And then she presented them with this, a continuum that ranged from medically necessary to cosmetic, and said, if these are the endpoints of the continuum, what kinds of interventions would you describe as lying along it? And invited them to put the interventions that their team actually did on this continuum. This wasn't possible with everybody because some people didn't want to do it or drew diagrams that we couldn't interpret, or the interviews were done on the phone. But 24 DSD professionals in the UK and Scandinavia did make this and made 156 marks in toto, okay? And then they talked about it and we analyzed those elements of the transcript. That's what I'm going to talk about today. Now, the reason we did this is because obviously, as we all know, in human rights documents and in laws in some countries, the distinction between medically necessary and cosmetic and normalizing interventions is becoming very, very real. But when we look at those documents, it is defined and exemplified in very, very different ways. And in addition, it is a question as to the extent to which medical knowledge is necessary to define that very boundary. So some of the things that are emerging in human rights documents, on the one hand, are there to limit medical intervention. That's the intention behind the documents. But at the same time, the documents seem to rely to a variable extent on medical expertise to define what is and what's not medically necessary. So this is a continuum, not a category, so it should be a little bit easier. So can DSD healthcare professionals do this? What do they draw down upon when demanded to do so? Here are the kinds of things that they mentioned, and we were able to categorize these thematically into interventions that were talked about primarily as focusing on a site of the body, primarily in terms of the functions they were imagined to serve, or the group of people to whom they were addressed. This is the number on the left, and on the right is the range of where all those interventions fell on the 0 to 100 point scale. You can see the range is quite wide for most of these, and that doesn't simply mean that DSD professionals don't agree about anything at all diagnostically. Of course they do, and often they would describe more than one intervention on a site and put it at different points in the continuum and that sort of thing. But there were some psychosocial reasons that came out across the interviews for why they differed from each other that had nothing to do with what one might consider to be medical knowledge whatsoever. One of those was projections about what the future life of infants and young children might be. So this was very clear in the case of interventions on the penis and the scrotum, which of course most obviously was talk about interventions that might be done on hyposphadias. So one clinician, for example, gave the quite traditional approach that this was medically essential by saying it was important to give the young person an opportunity to, particularly as a boy to, be continent, to not least stand up at the urinal with his pals and pee in the pot at the same time. Another clinician expressed an almost opposite point of view, saying, the reality is that doesn't happen, that being the scenario described in the previous quote. Because children these days do not look at other children's penises. They just don't do that. So I'm not sure whether it's medically essential. So the point I want to make here is that these clinicians have different points of view on this point, but what they're disagreeing about is not necessarily something medical. It's something to do with the social life of boys as they're standing at the urinal, perhaps in their school, perhaps between the ages of 8 and 10 or something like that, when this teasing is or is not imagined to take place. And it's reasonable for them to disagree about this because the medicalization, the almost exclusive medicalization of this area has meant that there hasn't been any good developmental psychology that could possibly address this question and inform their opinions. So no surprise they fall back on different common sense ideas of what little boys do or don't do in this kind of context. Second reason for ambiguity is that people had different views about the impact of advocacy groups, which have been arguing for reductions in interventions or complete cessation of them. As one person said, I can hear some of what advocacy groups are saying. So medicine is not hermetically sealed, separate from advocacy, but DSD professionals' opinions are informed by what they think advocacy groups are doing and whether they've got something to say. Again, very different perspectives came out. One clinician said these things are absolutely not on my planet in regard to clitoral interventions. Another had a way of talking around their necessity, saying clitoral reduction in child is purely for cosmetic reasons and to keep parents happy, really. So these are clearly psychosocial normative reasons. But then they continued, but also it's, how does that child cope with school and all that sort of stuff, arguing for a kind of essentialness on the basis of something that's clearly social rather than biomedical. Perhaps the area where this was sort of hardest for the clinicians to draw the line was around interventions in the vagina. And looking at the transcripts, it was here that I had the impression where we saw the most interrupted speech, the most half-started sentences that were corrected, the most uhs and ums. All of those things that sort of suggest to me that people were thinking on this on the fly and forming their opinions as they talked. One clinician asked themselves this question in the middle of the interview, do you need a vagina for medical reasons? And they continued, that's the question really, isn't it? Most people will argue yes in order that you want to be sexually active in order to maintain your general health and things like that. This clinician was under no doubt that her patient might want a vagina and that it would be a good thing to be able to help her to have one for all of these reasons. but she was unclear if that in itself constituted a medical reason, because she was unsure if that was a domain of medicalization. Another person but a slightly different framing on it, saying it depends whether you want to medicalize the body and say that they are medically essential because you need to repair the body, but then they would probably say they're more for sexual functioning. So sexual functioning, that term, or functioning in general, was incredibly vague in these interviews and seemed to talk about, seemed to be a way of politely but obliquely talking about sex and sexuality. And so it was very hard to code. But I think sexual function is something that some people clearly would locate within the domain of legitimate medicalization, and some people would locate beyond it. So drawing the line is done very differently by DSD healthcare professionals. And in so doing, you can see that what they are doing is drawing on different models of what their patient is. What is the person in front of them? And they have three ways of conceptualizing that across these interviews. One is to think about the patient as a biomedical body that can be diagnosed, right? And to talk about anatomical features as if they were just physical things and nothing more. Secondly, they talk about patients as psychosocial subjects whose bodies are situations, developing situations, changing situations, with whom people might have psychological interactions with, which are meaningful and which they might want to enable. And thirdly, they talk about adult patients as choice-making adults who are responsible for their decisions, meaning that bioethical questions for these healthcare professionals seem pretty minimal and pretty non-dilemmatic in those contexts. So what I want to move from here to the second half of the talk and to move to more quantitative forms of psychology and explain a little bit how that fell out from the first project. But just by way of segue to say that I think what we've seen from the SENS project is that DST professionals are in agreement with each other where boundaries of medicine lie. Rather, but in addition to that, a historical point that I would make, and I think Ian's work in the Phocology book is extremely important here, is that medical rationales for intervention are and have always been human, but they have also presumed that our societies cannot tolerate people with naturally occurring VSC. Yet, it seems that because things have been studied by medicine and very little by psychology, and only by clinical psychology at that, what we are missing are studies of what public understanding of intersex actually is, the sort of thing that Della Grace and others are, of course, trying so actively to change through their activism and their art. And I think that in psychology, we probably haven't studied these things because of an effect of the stigma itself. And that's perhaps why social psychologists haven't done it until recently. But Ian mentioned this paper here, which is also calling for research on that. So I've tried to pick that up in my work in the last few years. I'm not the first person to do it. And this paper by Jörg Struli in Switzerland a few years ago shows something important, which is that the way in which variation is framed, again, as Del said, has an implication for how people think about medical necessity and what's medically essential. In this study, trainee doctors were asked to imagine that they were parents who had just been delivered of a child who had ambiguous genitalia, I believe is the word used in the experiment. And they were randomly assigned to receive this information from someone who was dressed in a white lab coat and spoke in biomedical language, or the same gentleman who was dressed in a sports jacket and who spoke in psychosocial language. In the first condition, the majority of medical trainees playing the part of parents said that they would choose surgery. In the second condition, the majority said that they would reject it. So this shows in a very simple way how framing might have an effect on how people think about what is and isn't medically essential when they're making those decisions on behalf of other people. These days, framing, of course, doesn't just happen in clinical contexts like this, it also happens in the public. So a few years ago, I did an experiment looking at psychology students in Surrey who were randomly assigned to watch one of two videos available on YouTube in which people speak from personal experience. The first is the Intersex Youth Advocacy Group. I'm just delighted that Saifa is in the audience today. That's fantastic. And the second one is the NHS Choices video, Disorders of Sex Development, to which Dan Wood made a major contribution, who's also in the audience today. So everybody's here. after watching one of the two videos, we measured students' beliefs about intersex people as a group and their beliefs about whether medicine did harm or delivered benefit to intersex people. And a comparison group of students completed these same measures but watched neither videos, giving us a baseline measure. And this was done with two students, Annette Smith and Tig Bogan-Carey. Here's what we saw in terms of beliefs about intersex people as a group. I was sort of making up how to measure this at the time, but we kind of had measures of whether the students thought intersex people were normal and natural, whether they were curious to learn more about the topic, and whether they were optimistic that intersex people could be fully included in society and flourish relatively easily. The video didn't really affect students' beliefs about this, but the students' beliefs on the whole were pretty positive across the board. The videos did, however, affect how the students thought about medical harms and benefits. The red group here in the middle are the group who watched no video, the baseline. To the left of them in blue is the group who watched the BuzzFeed video with Saifa. And students who saw that saw medicine as more harmful and less beneficial than baseline. The group to the right in green are the ones who saw the NHS Choices video with Dan, and they considered medicine to be less harmful and more beneficial. So this study, I think, says something, perhaps for discussion, that attempts to intervene in public consciousness seem perhaps to change beliefs about medicalization, harms and benefits more immediately than they change beliefs about intersex people as a group. Maybe that's a point for discussion. We've also looked at framing in regard to simple linguistic choices. This is Annette Smith's dissertation. And in this study, we had the hypothesis, sort of based on writings by Morgan Carpenter and many other people, that human rights violations would be tolerated to a greater extent if we described clitorectomy as being performed on a child who is intersex rather than a child who is described as female. So 122 participants were randomly assigned to read about intersex or female clitorectomy, but the description of the procedure was otherwise the same other than that matter. They then indicated their support for 22 items on human rights on 7-point scales, and we wrote those items by adapting them closely from human rights policies and academic articles about intersex and about FGM. And we measured several psychological measures. We found support for our hypothesis because students did indeed, or sorry, they weren't students, they were just regular folks. The people did indeed think that on the whole, they supported human rights in this case, but they supported it more in the case where the infant was described as female than when the infant was described as intersex. That was particularly true of people who had a high trust in medical authority, and it was not at all true of people who had a low trust in medical authority. So if you don't trust medical authority, these things seem very similar to you. However, if you do trust medical authority a lot, then these things seem very different to you. The biggest study we've done on public opinion so far, just a little bit of backstory. In 2016, David Griffiths and I did some stakeholder groups at Surrey to identify new areas of research, of which one was public understanding. The BPS funded a 2-part study on public understanding, which we conducted with stakeholders. And in May, we ran that study online, looking at lay people's understanding of umbrella terms, which Ian discussed, and attitudes about medical and societal responses to people with intersex characteristics. I'll only talk about the second half of that study today. So as I say, the study was co-designed with stakeholders in line with emerging guidelines on best practice research in human rights documents and intersex studies more generally, and was presented to a medical audience at the IDSD conference in Copenhagen in July 2017 by me, about when it was very hot off the presses. So 271 people in the UK and in the United States on the Prolific site took part. We deliberately oversampled people who identified as LGP+, and people who are parents. We attempted to oversample people who had healthcare work experience, but we weren't able to do that because of the limitations of the sample on the site. We gave people little briefings on the topic and measured using 7-point scales how much they supported several kinds of responses. Early medical interventions on children of the sort we've been discussing, how much they were sympathetic with parents who might be delivered of a child with VSC, their belief in the power of positive parenting to bring about the flourishing of such children, support for support groups, support for legal prohibition of medical interventions, the human rights strategy, and lastly, support for social equality responses, inclusion of intersex and discrimination legislation and things like that. So let's call the first one a medical response and the last psychosocial responses. And indeed, it all kind of statistically, I could back that up. They do seem to cluster that way. So people are often very interested in demographic variables that predict these kinds of things. And here are some things we measured that had little effect or no effect at all. Country, doesn't matter at all. Gender, conceptualized as binary here with caveats, of course. Women a little bit more negative about medical intervention, but not a big difference. Ethnicity, again, conceptualized as binary just for the limits of the sample, doesn't make a difference. Nor religiosity, nor self-reported class, nor parental status, nor whether you've worked in healthcare work or not, nor what your highest educational attainment that you report is, nor what you report your age to be. So far we're doing a terrible job, and absolutely nothing seems to predict who might have different opinions about medical versus psychosocial responses to people born with VSC. But there is one thing that makes an enormous difference, and that is, what is your self-reported sexual identity? It's enormous, and it affects everything. So people who are self-identifying as heterosexual in the sample are more in favor of early medical interventions on infants than are people who are LGBT identified. However, people who are LGBT identified are more sympathetic with the difficult emotions of parents who might be delivered of such a child, and believe more in the power of such parents to bring about the flourishing of their child. They are also more supportive of intersex specific support groups, including being willing for their tax money to go towards them. They're vastly more in favor of human rights legal limitation, and much more in favor of intersex people being included in discrimination law and stuff like that. I think we'll talk about this topic later. Just to say, we replicated that in a second study. This is Hayley Kingsbury's dissertation on analogies that people draw when they hear about intersex. We sort of replicated it there using a similar sampling method. So in conclusion, what I kind of want to say from my social, psychological, disciplinary standpoint in the lovely interdisciplinary space of Critsex is that I think social psychological rationales have always been the primary basis for controversial medical intervention. And I think Ian's writings about John Money in the Fuckology book show that very clearly. Secondly, medical necessity is not a natural kind any more than DSD or anything else is. Rather, it depends on opinions about psychosocial questions that are not evidenced or researched, but also often informed by people's understanding of controversies and their imagination of what the social life of children might be. Third, public opinion about medicalization is subject to social influence via framing, but it also differs systematically among social groups, LGBT plus versus heterosexual people, for example. Fourthly, demedicalization, as it sort of goes forward in the future, may indeed involve human rights-based legislation and limits. That seems very likely. But I think it also is likely to and must involve, if it is to be humane, better expertise in psychosocial professions. And I would include broadly here things like social work, primary education, and other things. And I think if the more we develop these things, this will enable us to ask less of medicine and less of the multidisciplinary teams, which are stretched for the reasons that Ian so nicely described. And I suppose my last point is to think about how I am now listening to DSD professionals in light of this work, because I think what I'm delivering in this work is some good news. I think I am in some ways falsifying the hypothesis, which has never been tested for the last 70 years, that our society will never accept people with VSC, will never accept whether they identify as intersex or not. Seems to me actually lots of evidence that there might be lots of tolerance and positivity out there, as well as stigma. And it's interesting to see how DSD professionals respond to that. Do people want to do, as Dan suggested, enter much broader, much more multidisciplinary partnerships to support the flourishing of people with VSC? Or is this good news treated as bad news because it suggests to a threat to medical authority? And I'm sort of listening to those kinds of voices as I'm thinking about the kinds of medics that I might want to collaborate with in the future ethically. Thanks very much.
Thank you so much, Peter. Yeah, thank you, Peter and Ian, for two fantastic papers as part of this panel. We'll go pretty much straight into questions for reasons of timing. We will, I think, we'll probably have a conversation until at least 4 o'clock, and then we'll make sure that we have a good 10-minute break before we move on to our third panel. If I could ask, though, that you could address any questions specifically to Peter and Ian's papers, we can then save any more general discussion for our final panel, where we'll have a chance to hear from our respondents as well. So, as I promised, then straight into questions. If you have a question, you can either write that into the chat or the Q&A box. You can also raise your hand and I can invite you to talk then out loud.
I can do a quick one while we're waiting. So Pete, just the very last point, and I was just like, what? People are becoming more positive about VSC in the midst of a trans moral panic. Can you speak to what the different, why are people okay with VSC and not okay with trans at the same time?
Well, I think those things are related. So first of all, I'm not saying that people are becoming more okay with VSC. I think they really are. And I think actually the things like the fact that BuzzFeed video was so viral, 5 million people have watched it in 5 years as of today, is saying something. Secondly, I think, this is occasioned by the transgender moment, right, in some ways. So I think the trans moral backlash is a response to something that happened that I think has also enabled this moment. And there's sort of a few reasons why I think that kind of empirically. I mean, one is we in some of these studies we've been looking at measures of how much people believe in the gender binary. A measure I developed years ago with Nicola T to look at trans rights. And it's massively predictive of how much people like early medical intervention and things here. And you won't be surprised, LGBT plus and heterosexual people vary on that. And secondly, what's clear to me when we ask people, what does the word intersex call to mind to you? Or they read interview transcripts from Georgianne Davis's work and we ask them to think of analogies. Trans and non-binary people are a very, very, very available analogy. So I think trans and non-binary people are much more familiar to many people in the culture than intersex people are. And they're sort of an available category through which people are scaffolding their understanding of what intersex might be about.
Brilliant, thank you, Peter. So I'm still waiting for questions. I don't know if any of our other panelists have a question for Peter or for Ian.
Wait, can I add something on the back of what Peter has just said to Meg John, which is, I suppose what's interesting is that is thinking about the fact that the David Reimer case was seen by some as an allegory of transsexuality. So we've got lots of things allegorizing for each other here, which I suppose both, to use that really great word, as you said, Peter, scaffolds understanding. But I guess sometimes it can feel a little bit like a merry-go-round of having to say, well, this thing is like this other thing. So don't worry, because it's like this thing you already know. And that is also like this other thing. And that's a bit like something else. And sometimes you can lose some of the specificity. Yeah. Something I've often tried to bring myself back to in my writing, because obviously I take quite a theoretical perspective, but ultimately we are talking about genitals being cut off, and that's very specific, and so I think the allegories can be useful, but we also need to keep a grip on the practices that we're really wanting to challenge.
I would agree. I'd just quickly say, I think analogy is a step towards public understanding, but it's not analysis and it's not the last step.
There is a question for Ian, and this is from Hannah. This is a question for Ian. I wonder how aware are medical professionals, particularly specialists, of the history of their disciplines and the power relations naturalized in their practice. And I say this as something doctors fail to acknowledge in their formation.
Yeah, I think the big kind of ghostly presence in medical practice is, of course, John Money, whose work was absolutely formative on the current practice still, and yet has now all references to his work have kind of disappeared from medical papers. And in a funny way, some of the papers have actually got worse because of that. And the specific example I'm thinking of, for instance, is the work by Pierre Mouriquan and his team, where they come out with absolute nonsense about gender and social roles and identity and the social self and the gendered self. They have no idea what they're talking about. I mean, there's no conceptual framework. It's just a random group of terms that they swill around. And in a funny way, Money's terminology around gender identity and role at least provided some kind of framework to talk about these concepts. So although I'm very glad that the era of Money is, is in the past, I think his influence is still there on practice. And I think we've actually moved to a point where discussions around gender and what it means to be gendered in a way have become more impoverished by the lack of terminology that he provided. So as Lisa and Nikki and I wrote in Pharmacology, his legacy is very mixed. It's extremely mixed, both in its uptake and its effects. So I think that history is definitely not openly recognized.
Thanks, Ian. There's a question for Peter. He's so prolific. What's on his agenda next? That's the question for you, Peter.
Well, I've just moved jobs, so getting my head around that is large at the moment. I think one thing that's occupying my time a lot at the moment, but I can't talk about it very much, is I'm part of the American Psychological Association task force that is looking at what it's calling differences of sex development at the moment. And this is something that the APA is doing under its public interest directive, in part because of moves that have happened within APA, in part because of pressure from human rights advocates in the USA and elsewhere. The stuff about this on the website, you can see this, but I think it's, I'm one of a group of people who's responding to this charge from the Council of APA to think about what is known in psychology, what's not known, what are the gaps in the literature, and what do we need to do to improve clinical guidelines and things like that. So that's probably the thing that's most obviously occupying me in this space at the moment.
Thanks, Peter. Okay, this is from, another question for both of you. What topics, themes need more research, do you all think? Peter, yeah.
The social life of children. Ian wrote something about 20 years ago that described the imagined scene of a child with VSE being bullied in school as being a rationale for surgical intervention. We would not tolerate that in other contexts. We would say that is bullying, and we would think about it in the social context of bullying in school. And I think that we need to do this psychosocial move, but we really need to do it around children.
Del, do you want to come in there?
Yeah, I would like to. I mean, I think I have like this great parental laboratory here, and I have a child who has their own changing room. They are other kids in their school who, I guess Mika would be considered to be in 4th grade, almost 9 years old, and experiences no bullying. It's actually the other way around. And I mean, part of the reason why we are so public with this is because I think it actually is such a repudiation of that idea that being different I mean, Mika was assigned male at birth, and Mika has now a very consciously non-binary look, but for many years was more on the feminine scale. and now is leaning more towards non-binary or androgynous. But far from, Mika actually will talk about how they think this is something that makes them more rather than less popular. And it's the same for the 6-year-old child. And I know that Mika and Nico are not the only ones. And I know that this is perhaps rare outside of Sweden. I don't know. But I think you can look, I think the intersex, I guess what I'm interested in hearing from everybody about is, what potential do you think the non-binary movement is, which I've been waiting for 25 years to come around. What potential does that have for intersex, cosmetic intersex interventions? And maybe that's something for a larger discussion, but I wanted to put that out because I don't see it as being, it's a truism, it's a cliche. It's just not universal that children that have some kind of physical or gender difference are necessarily bullied. It doesn't have to be.
Yeah, I think what I've tended to see reading interviews that researchers have done with parents and with clinicians is that there's a lot of people pointing fingers at each other in a circle to suggest why surgery must be done, right? So the parents say, if you ask them, why do you need to do this? They say, well, the doctors told us. And then if you ask the doctors, they say, well, society says we should do it. But then, as Peter found, kind of that society is not one thing, right, with a single view. So if you go back to the parents and say, well, the doctors aren't sure, so tell us again, then the parents say, oh, well, because of society. so it becomes this kind of circular set of fingers pointing at each other saying they told me to do it. It was their idea.
Thanks, Ian. I wonder if it's time for a pause, given that we've still got our third panel as well as respondents to speak. I just want to say thank you again to Ian and Peter. There's such fantastic crossovers with your papers, particularly on this idea of the kind of performed role of the clinician. I mean, your example, Peter, of the difference that a lab coat makes as opposed to a sports jacket. I mean, it's really astounding. So yeah, thank you both. And we'll just have to imagine the kind of rounds of applause or, to congratulate you on your papers. Okay, so we'll take 10 minutes then and reconvene at 4:15 to move on to our third panel. Thanks again. Thank you.